Next we have Natasha to tell us about exudative RD.
Our next speaker is Dr. Natasha Radhakrishnan, who is well known in KSOS. She is a professor in Amrita Institute of Medical Sciences.
So my case is a typical case of exudative retinal detachment. She was a 32-year-old lady who presented to us because she was on investigation for interstitial lung disease and was on MMF and systemic steroids, suspected to have systemic Sjogren's. And she was referred to us with mild blurring of vision, but she was 6'6" with some sensory neural detachment areas away from the fovea. Left eye also had the same picture, and autofluorescence at that time showed a few RPE changes in the area of the sensory neural detachment in both eyes. This was the detachment, and you can see that the raster is away from the fovea there in the right eye. Both eyes, the fovea was not involved. But we thought it was a steroid-induced CSR. So we did a fluorescent angiogram, but we couldn't demonstrate any CSR leak, either monofocal or multifocal in both eyes. ICG just showed vague areas of hypofluorescence and again no leakage. So still we went ahead with the diagnosis of CSR, and we advised to taper and stop the steroids. A month later, her vision had dropped to 618 in right eye and 69 in the left eye. Fluid has increased, the autofluorescence showing extensive RPE changes. Fovea was spared, but everywhere else. ICG showed marked hypofluorescence and few areas of hyper as well, and FFA showed multiple hyperfluorescent areas. This was the fluid at that time. You can see that the fluid has thickened in the foveal area, and this was the ICG and the FA. The ultrasound B scan showed a choroidal thickening, which was quite significant. So then we changed our diagnosis to maybe it is inflammatory VKH. With a ESR of 101, she was having systemic activity also, and we told them to increase the immunosuppression. IVMP was given in taking into consideration her dropping vision, and MMF was increased to 1 gram TDS. But her vision continued to drop. Now she became 636 in the right eye, left eye between 6.6 and 6.9. And this was the picture then. The fluid has increased. Those RPE changes, which is very well seen on autofluorescence, has increased significantly in all over the fundus. And we still did not have a diagnosis. She was further worsening 2 weeks later. Again, all the changes are worsening. Mild disc edema started developing in the right eye. This shows the continuous progression and the increase in the edema while she is on immunosuppression. We discussed with pulmonology. They repeated their HRCT and found that the interstitial lung disease activity had come down significantly. I was messaging all the UVA and VR consultants across India because she's a young lady and she's rapidly losing vision. And we came down that the leopard spots that we are seeing on the autofluorescence may be suggestive of uveal effusion syndrome or some VKH-like inflammation, which of course we had ruled out by giving the anti-inflammatory. While all this was going on, she presented with severe backache. MRI spine showed an aggressive myeloproliferative disorder bar neoplasm. And then ultrasound abdomen showed bilateral ovarian deposits. Bone marrow showed primary in breast and metastasis in the bone. Bilateral breast invasive lobular neoplasm was found with extensive metastasis. And a retrospective diagnosis, we came to bilateral diffuse uveal melanocytic proliferation as a paraneoplastic syndrome of her breast carcinoma, B-dump. And then on chemotherapy, she stabilized at around 6.9 in the right eye and 6.12 in the left eye. And this is her last picture on follow-up with us. And this is how much the RPE has been destroyed by the paraneoplastic syndrome. This was the final OCT at last follow-up. We were fooled by her young age because we never thought of malignancy because she was only 32. The inflammatory nature of her lung lesion and the Sjogren, the diagnosis that the pulmonologist already gave us, the pinpoint hyperfluorescence and RPE damage that kept progressing, choroidal thickening that made us think that it is probably inflammatory, and the lung condition was getting better also. So B-dump was first described by Makimer and then further by Gas, and 5 cardinal findings they show are reddish-brown lesions at the level of the RPE, hyperfluorescent spots on the FA, slightly elevated pigmented or non-pigmented tumor-like lesions and diffuse thickening of the uveal tract, exudative retinal detachment, rapid development of cataract. That last feature we did not have in our patient. So I just wanted, this is a very rare case. It's not like bidums walk into our OPD every day, but at least we should know when exudative retinal detachments are not the straightforward multifocal CSR or VKH, which are the two differential diagnoses that we always think of when they come with exudative detachment. And also for the audience, the multifocal CSR differentiation from VKH.
First thing, because I had some cases like this, not related to this, but which was mistaken was atypical CSR, and then finally turned out to be VKH. But I think that what I felt that you have to see findings of inflammation like vitritis or some inflammatory, then only you can put it as a uveitis. If you see a serous elevation without any inflammatory element, we should consider CSR. And uveal effusion syndrome. Obviously, there is a possibility of because we have a young lady now who has bilateral CME without any other features. She has been on so many treatments, but there is no inflammation, nothing. Bilateral CME. But with just observation, she is improving. Her axial length is normal, so no features of nanophthalmos and all. But still, I told them the possibility of this uveal effusion, and it has recovered. But this is a definitely rare case. But I think the inflammatory element was the feature which is against.
Absent.
You see, uveal effusion also is not a diagnosis. Uvulation is just an anatomy only. It's not a diagnosis that you say. But what I wanted to stress was, in case you have serous NSD detachment, FA not showing picture of CSR, think of systemic condition. That is the lesson to be learned. You see, if you have OCT shows CSR like fluid or nuclear detachment, but FA does not show that leakage, then think of paraneoplastic syndrome or sometimes leukemia also, malignancy also, or P-dump also.
Yes, that is a very important point.
And second point I wanted to highlight was those RP irregularities, which I think she showed, you also showed. RP irregularities, they never occur in idiopathic CSR. So bilateral CSR, where steroids are contraindicated, vis-a-vis VKH, where steroids are indicated, and even immunosuppression indicated, has to be differentiated.
I think Dr. Divya's case also, multiple myeloma most of the time presents to us with non-ischemic CRVO. So when the SND came in, that would probably be one of the differentials. And also we can have among these drugs that are given for treatment of chemo, there is drug-induced VKH also. So all of that can be differentiated by looking at the FA picture. That would give us a good, but yours was well spotted that it is in relation to the drug that fluid has come in and it got. So both these conditions can be treated by just treating the primary condition, and then the fluid subsides. Of course, vision is reduced and compromised.
Natasha, you stopped steroids and everything increased in your patient.
Yes.
In your patient, you stopped steroids, everything increased. So they are not typical features of CSR.
Correct.
A lot of learning from these two cases.
Yes. So exudative retinal detachments, especially with extensive RP changes, we should think of systemic cause and the possibility of a paraneoplastic syndrome. Don't be fooled by the age like we were.